Good afternoon, dear students. We continue our lectures, and the topic today is pneumonias. Pneumonia results from the proliferation of microbial pathogens at the alveolar level and the host's response of those pathogens. Microorganisms gain access to the lower respiratory tract in several ways. The most common is by aspiration from their oropharynx. Small volume aspiration occur frequently during sleep and in patients with decreased levels of consciousness. Many pathogens are inhaled as contaminated droplets. Rarely, pneumonia occurs via hematogenous spread or by contiguous extension from an infected pleural or mediastinal space. Mechanical factors are critically important in host defense. The hairs and turbinates of the nares capture longer inhaled particles before they reach the lower respiratory tract. The branching architecture of the tracheobronchial tree traps microbes of the airway lining, where mucociliary clearance and local antibacterial factors either clear or kill the potential pathogens. The gag reflex and the cough mechanism offer critical protection from aspiration. In addition, the normal flora adherent to mucosal cells of the oropharynx, whose components are remarkably constant, prevents pathogenic bacteria from binding and thereby decreased the risk of pneumonia caused by these more virulent bacteria. When these barriers are overcome, or when microorganisms are small enough to be inhaled to the alveolar level, resident alveolar macrophages are extremely efficient and at clearing and killing pathogens. Macrophages are assisted by proteins that are produced by the alveolar epithelial cells and that have intrinsic opsonizing properties or antibacterial or antiviral activity. Once engulfed by the macrophage, the pathogens, even if they are not killed, are eliminated via either the mucociliary elevator or the lymphatics and no longer represent an infectious challenge. Only when the capacity of the alveolar macrophage to ingest or kill the microorganisms is exceeded does clinical pneumonia become manifest. In that situation, the alveolar macrophage initiates the inflammatory response to bolster lower respiratory tract defenses. The host inflammatory response, rather than proliferation of microorganisms, triggers the clinical syndrome of pneumonia. Inflammatory mediators released by macrophages and the newly recurred neutrophils create an alveolar capillary equivalent to that seen in the acute respiratory distress syndrome. Also, in pneumonia, this leak is localized. Even erythrocytes can cross the alveolar capillary membrane with consequent hemodialysis. The capillary leak results in a radiographic infiltrate and rails detectable on auscultation, and hypoxemia results from alveolar filling. Moreover, some bacterial pathogens appear to interfere with the hypoxemic vasoconstriction that would normally occur with filed alveoli. And this interference can result in reserve hypoxemia, increased respiratory drive in the systemic inflammatory response syndrome leads to respiratory alkalosis, decreased compliance due to capillary leak, hypoxemia, increased respiratory drive, increased secretion, and occasionally infection-related bronchospasm all lead to dyspnea. If severe enough, the changes in lung mechanism secondary to reduction in lung volume and compliance and the intrapulmonary shunting or blood may cause respiratory failure and the patient death. Pathology of pneumonia. Classic pneumonia involves through a series of pathologic changes. First, edema of tissue, presence of a proteinaceous exudate and often of bacteria in alveoli clinically is non-distinguishable. Second threat, hepatization, presence of erythrocytes in the cellular intraalveolar exudate, neutrophil influx bacteria are occasionally seen. Third, grey capitalization. No new erythrocytes are extravasating, and those already present have been lysed and degraded. The neutrophil is the predominant cell, fibrin deposition is abundant, and bacteria have disappeared. And fourth, resolution. The macrophage reappears as the dominant cell type in the alveolar space and the debris of neutrophils, bacteria, and fibrin. Types of pneumonia includes bronchopneumonia, lobar pneumonia, and intestinal pneumonia. Bronchopneumonia affects one or more lobes, being frequently bilateral and basal. Microscopically, one can identify multiple foggy of condensation, white, yellowish, impresently circumscribed, centered by bronchiole, separated by normal lung parenchyma. Lobar pneumonia is a radiological and pathological term referring to homogeneous consolidation of one or more lung lobes, often with associated pleural inflammation. Intestinal pneumonia is a pneumonia that affects intestinal tissue, interstitial tissue of the lungs. Typical lung finding is usual interstitial pneumonia. Fibrosis of both lobes can be seen with honeycomb change involving primarily the lower portions of the lobes. Usual interstitial pneumonia is an abrupt transition from honeycomb change to normal lung, especially homogeneous pattern of fibrosis seen in non-specific in interstitial pneumonia. Clinical presentation. A patient should be suspected of having pneumonia when one of the following signs and symptoms are present. New focal chest signs, dyspnea, tachypnea, pulse rate more than 100, fever more than 4 days. The classic physical findings in lobar pneumonia include evidence of consolidation with altered transmission of breath sounds, echophony, bronchial breathing, and whispering pectorality. Crackless, scattered, raunchy, crepitation, reduce and induce changes in tactical fremitus, pleuritic pain. When consolidated, the lungs is typically dull to percussion. What general investigation should be done in a patient admitted to hospital? Oxygenation saturations, and where necessary, arterial blood cases in accordance with the PTS guideline to emergency oxygen use in adult patients. Chest radiograph to allow accurate diagnosis. Urine and electrolytes to inform severity assessment. C-reactive protein to aid diagnosis and as a baseline measure. Full blood count, liver function test. When should a chest radiograph be performed in the hospital? All patients admitted to hospital with suspected CAP should have a chest radiograph performed as soon as possible to confirm or refute the diagnosis. The objective of any service should be for the chest radiograph to be performed in time for antibiotics to be administered within 4 to 6 hours of presentation to hospital. Should be diagnosis of CAP be confirmed. When should the chest radiograph be repeated? During recovery. The chest radiograph need to be repeated prior to hospital discharge in those who have made a satisfactory clinical recovery from community-acquired pneumonia. A chest radiograph should be arranged after about 6 weeks for all those patients who have resistance of symptoms or physical signs or who are at high risk of underlying malignancy. Whether or not they have been admitted to hospital. CT finds pneumonia. Lobar pneumonia can have has a pattern of focal ground glass opacity in a lobar or segmental pattern. This is due to incomplete filling of alveoli and consolidation. At other times, there can be dense opacification of the entire lobe. Bronchopneumonia, multiple foci of opacity can be seen in a lobular pattern centered at centrilobular bronchioles. This may result in a 3-in-bud appearance. The foci of consolidation can overlap to create a longer heterogeneous confluent area of consolidation or patchwork coiled appearance. Interstitial pneumonia, ground glass opacities combined with irregular linear or reticular opacities, regular opacities. Thickening of bronchovascular bundles with NSIP with fibrosis. Why are microbiological investigation performed? Microbiological tests should be performed on all patients with moderate and high severity community-acquired pneumonia. The extent of investigation in this patient being guided by severity. For patients with low severity pneumonia, the extent of biological investigations should be guided by clinical factors, epidemiological factors, and prior antibiotic therapy. Where there is clear microbiological evidence of a specific pathogen, empirical antibiotics should be changed to the appropriate pathogen-focused agent unless there are legitimate concerns about dual pathogen infection. Examination of sputum should be considered for patients who don't respond to empirical antibiotic therapy. Examination of sputum for Mycobacterium tuberculosis should be considered for patients with a persistent productive cough, especially if malaise, weight loss, or night sweats. Or risk factors for tuberculosis are present. Microbiological tests such as culture and gram stains are not recommended in primary care. Gram stains differentiates between organisms with thick peptidoglycal cells walls and those within peptidoglycan cells walls and other membranes that can be dissolved with alcohol or acetone. Gram stain is particularly useful for examining sputum for polymorphonuclear leukocytes and bacteria. To be adequate for culture, a sputum sample must have more than 25 neutrophils and less than 10 squamous epithelial cells per low powered field. The sensitivity and specificity of the sputum gram stain are highly variable. Routine performance or reporting of sputum gram stain on all patients is unnecessary but can aid the laboratory interpretation of culture results. Should be performed when a virulent sputum sample can be obtained from patients with pneumonia. Sputum analysis. Sputum samples should be sent for culture and sensitivity tests from patients with pneumonia of moderate severity who are able to expectorate virulent samples and have not received prior antibiotic therapy. Culture of sputum of other lower respiratory tract samples should also be performed for all patients with high severity pneumonia or those who fail to improve. Sputum cultures for Legionella should always be attempted for patients who are Legionella urine antigen positive. Legionella culture should be routinely performed on invasive respiratory samples from patients with pneumonia. Even in cases of proven bacterial pneumococcal pneumonia, the yield of positive culture from sputum samples is less than 50%. C-reactive protein is the most common laboratory marker used in the clinical setting to evaluate systemic inflammatory response to a bacterial infectious agent. C-reactive protein is an annular pentametric protein found in blood plasma whose levels rise in response to inflammation. It's an acute phase protein of hepatic origin that increases following interleukin-6 secretion by macrophage and T cells. Its physiological role is to bind to lysophosphatidylcholine, expressed to the surface of dead or dying cells in order to activate the complement system via the C1q complex. C-reactive protein is synthesized by the liver in response to factors released by macrophage and fat cells. This protein binds to the phosphocholine expressed on the surface of dead or dying cells and some bacteria. This activates the complement system, promoting phagocytosis by macrophages, which clears necrotic and apoptotic cells and bacteria. In patients with suspected pneumonia, a test for serum level of C-reactive protein can be done. This protein level of less than 20 milligram per liter at presentation with symptoms for more than 24 hours makes the presence of pneumonia highly unlikely. A level of more than 100 milligram per liter makes pneumonia likely. Classification of pneumonia. First, community acquired pneumonia is that which occurs in the absence of immune compromise or prior hospital admission within the previous 30 days. Second, hospital acquired pneumonia or nosocomial pneumonia can occur in anyone resident in hospital for more than 48 hours. Ventilator-associated pneumonia hospital common in the intensive care unit more than 48 hours after endotracheal intubation. Fourth, pneumonia in the immunocompromised, and aspiration pneumonia in those with swallowing impairment and neurological impairment. Community acquired pneumonia includes cases of infection pneumonia in patients living independently in the community. Patients who have been hospitalized for other reasons for less than 48 hours before the development of respiratory symptoms are also considered to have community acquired pneumonia. More than 5 million community-acquired pneumonia cases occur annually in the United States. This pneumonia results in more than 1.2 million hospitalization and more than 45,000 deaths annually. The incidence rates are highest at the extremes of age. Risk factors for community-acquired pneumonia include cigarette smoking, upper respiratory tract infections, alcohol, corticosteroid therapy, old age, recent influenza infection, pre-existing lung diseases, HIV, indoor air pollution, etc. Typical community-acquired pneumonia. The pneumococcus accounts for 50-80 of community-acquired bacterial pneumonias. Types 1 to 9 and 12 are most commonly found in adults. Essentials of diagnosis: sudden onset of shaking, chills, fever, chest pain, and cough with rust-colored sputum. X-rays show infiltration, often lobar in distribution, but sometimes patchy. During resolution of the consolidation, which may require 8-10 weeks, areas of radiolucency may appear, suggesting pseudocavitation. Pneumococci are present in the sputum and often in the blood. Leukocytosis, typical sputum from pneumococcal pneumonia, contained many red and white cells and many pneumococci. Staphylococcal pneumonia. Pneumonia caused by Staphylococcus aureus occurs as a sequela to viral infections of the respiratory tract and in debilitated patients. A history of a mild illness with headache, cough, and generalized aches that abruptly changes to a very severe illness with high fever, chills, and exaggerated cough with purulent or blood streaked sputum and deep cyanosis. The diagnosis must be confirmed by stained smear of sputum and culture, and also by means of cultures of pleural fluid and blood. X-ray examination reveals lung consolidation, pneumocells, abscesses, empyema, and pneumothorax. The demonstration of pneumothorax and of cavities with air fluid levels, Staphylococcus aureus. The diagnosis of this pneumonia, community-acquired pneumonia, nosocomial pneumonia, is based on the clinical presence of fever more than 39 grade, cyanosis, tachycardia, hemoptysis, hypertension, and rapid cavitation of infiltrates on chest radiograph, plus MSSA, RSA in respiratory secretions, risk factors, cardiopulmonary disease, alcoholism, or diabetes. Atypical community-acquired pneumonia. The eponym Legionnaires disease has been given to a serious pneumonia that afflicted people attending the American Legion Convention in Philadelphia in 1976. Other outbreaks have been diagnosed retrospectively at least since 1965, and sporadic infections have occurred at least since 1947 in many places. Legionella species occur in the environment and are occurred by humans from aerosols, dust from air conditioning systems, water, or soil. The incubation period is estimated to be from 2 to 10 days. Initial symptoms are malaise, diffuse mild gills, and headache, followed in 48 hours by high non-remittent fever and chills. Nausea, vomiting, and diarrhea are frequent early in the illness. On the third day, a dry cough begins that is non-productive or produced scanty mucoid, sometimes blood-streaked sputum. Dyspnea and hypoxia become marked as signs of consolidation develop. Pleuritic chest pain occurs in 1/3 of patients. Severe confusion or delirium may occur. Chest X-ray shows patchy, often multilobar pulmonary consolidation and occasionally small pleural effusions. Mycoplasma pneumonia is a common cause of community-acquired pneumonia, and the disease usually has a prolonged gradual onset. Mycoplasma pneumonia was first isolated in cattle with pleural pneumonia in 1898. PCR of respiratory tract samples, such as sputum, should be the method of choice for the diagnosis of Mycoplasma pneumonia. The patient's history may include the following: fever, generally low grade, malaise, headache, persistent, slowly worsening, incessant cough, a scratchy sore throat, wheezing, mild pharyngeal injection with minimal or no cervical adenopathy but no exudate. Normal lung findings with early infection but bronchi, rails, and or wheezes several days later. Tetracycline and erythromycin compounds are very effective. Chlamydia pneumonia characteristics. First, the incubation period is approximately 3-4 weeks. Symptoms develop in a biphasic pattern characterized by an initial period of upper respiratory tract symptoms, followed by symptoms of pneumonia after 1-4 weeks. Fever is present in the first several days, less often after 1 week. Cough is prominent with scant sputum production and may persist for weeks for 2 months. Chest X-ray, a single subsegmental infiltrate that is mainly located in the lower lobes. Viral pneumonia. Viruses cause 13 or 50% of pathogen diagnosed community-acquired pneumonia. Immunofluorescence assay and enzyme-linked immunosorbent assay for the diagnosis of HCV, RCV, influenza viruses A and B, PIV, CMV, and other respiratory viruses. ELISA can detect viral antigens, while an immunofluorescence assay requires the presence of prepared intact infected cells. This pneumonia is a highly sensitive and specific technique for amplifying genes to detect the presence of a virus. Viral culture used for isolation and identification of the pathogen. Tissue used for culture, sputum samples, nasopharyngeal portion, bronchoalveolar lavage, biopsy. 27% of causes are mixed bacteria and virus. For most common viruses encountered, influenza virus, respiratory syncytial virus, adenovirus, parainfluenza virus. Respiratory viruses multiply in the epithelium of the upper airway and secondary and infect the lungs by means of airway secretions or hematogenous fluid. Respiratory viruses damage the respiratory tract and stimulate the host to release multiple humoral factors, including histamine, Licatriene C4, and virus-specific immunoglobulin E, bradykinin, interleukin-1, interleukin-6, and interleukin-8. These infections can, after bacterial colonization patterns, increase bacterial adherence to respiratory epithelium, reduce mucociliary clearance, and after bacterial phagocytosis by host cells. Chest X-ray. Bilateral lung involvement, influenza, peripheral and peribronchial infiltrates, RSV, pneumonia, bilateral alveolar infiltrates, and interstitial changes, adenovirus pneumonia, bilateral and patchy, ground glass infiltrates with a preference for lower lobes. Treatment: Zaldemivir or zanamivir for treatment for all hospitalized patients with suspected or confirmed cases. For outpatients at increased risk for complications of H1N1 infection. Adults, 75 milligram capsule twice per day, 150 milligram twice daily in severe forms of the disease. Principles of antibacterial treatment of pneumonia. The guidance for empirical initial antimicrobial treatment should follow 3 basic considerations and overall 10 criteria. Prognostic assessment. The assessment of age, patients age more than 65 years are subdivided into those with moderate good ability and those who are severely disabled. The assessment of general prognosis. Patients with pneumonia as an expected terminal events of several comorbidities should be managed along principles of palliative medicine. Assessment of correct grouping. Previous hospitalization and antimicrobial treatment. Patients with hospitalization less than 3 months ago and those with repeated recent antimicrobial treatment should be classified as nosocomial pneumonia and treated accordingly. Risk factors for severe immunosuppression. This patient should be managed following the guidelines for immunocompromised patients. Assessment of factors determine selection of antimicrobial treatment. Severity. Also, severity has only a minor impact on microbial pattern. Broad combination treatment is mandatory in order to cover all potential pathogens and prevent extent mortality due to treatment failure. Comorbidity may have an independent bearing on potential underlying pathogens. Residents. Nursing home residents as such may not alter microbial patterns. Such risks should be assessed individually. Aspiration may be witnessed or suspected. May correspond to gross or silent aspiration. Regional and local patterns of microbial prevalence and resistance. Considerations of tolerability and toxicity of antimicrobial agents in the individual patient. How should response to antibacterial treatment be assessed? Patient's response to therapy should be evaluated at about 48-72 hours. Response to treatment should be monitored by simple clinical criteria, including body temperature, respiratory, and hemodynamic parameters. The same parameters should be applied to judge suitably for hospital discharge. How should patients with community-acquired pneumonia be monitored ambulatory? A patient should be advised to return if their symptoms take longer than 3 weeks to disappear. The clinical effects of antibiotic treatment should be expected within 3 days, and patients should be instructed to contact their doctor if this effect is not noticeable. Seriously ill patients meaning those with suspected pneumonia and elderly patients with relevant comorbidity should be followed up to days after the first visit. Chest radiographic abnormalities are slow to resolve, with the speed of clearance depending on the patient's age and underlying lung disease. Aspiration pneumonia should be considered in patients with difficulties with swallowing, who show signs of an acute LRTI. In this patient, a chest X-ray should be performed. Predisposing factors include impairment of the swallowing mechanism, inadequate cough reflex, impaired gastric emptying. When should aspiration pneumonia be suspected? In those with community-acquired pneumonia, which either first follows an episode of witnessed aspiration, or second occurs in the presence of risk factors for aspiration. Traditionally, post-enteranterial and lateral chest radiographs have been recommended for imaging aspiration pneumonia and its complications. CT scanning is the best method for diagnosing aspiration pneumonia and abscess or an empyema. CT scanning previously deletes the line, the location of the lobar or segmental opacity. A foreign body in the tracheobronchial tree and associated atelectasis or consolidation can be defined with relative ease on CT scans. Magnetic resonance imaging is more sensitive than plain radiography. The patient's swallowing mechanism can be studied by using fluoroscopy with a contrast agent in the real life. A radionuclide salivagram can demonstrate the aspiration of saliva. Salivagrams can document salivary aspiration as the source of recurrent pneumonia. What empirical antibiotic treatment is recommended for aspiration pneumonia? Empirical antibiotic therapy should be initiated rapidly once the diagnosis of aspiration pneumonia is made. The regimen can be modified later after culture information from sputum, tracheal secretions, or bronchoscopic sampling is available. Hospital-acquired pneumonia is pneumonia that occurs 48 hours or more after admission and did not appear to be incubating at the time of admission. Healthcare-associated pneumonia. Healthcare-associated pneumonia is a bacterial infection that occurs in people who are living in long-term care facilities or have been treated in outpatient clinics, including kidney dialysis centers. Inhalation, aspiration, and hematogenous spread are the main mechanisms by which bacteria reach the lungs. The development of nasal pneumonia represents an imbalance between normal host defenses and the ability of microorganisms to colonize and then invade the lower respiratory tract. Common bacteria involved in nasal pneumonia include the following: Pneumonias aeruginosa, Klebsiella pneumoniae, Escherichia coli, Staphylococcus marcensis, Acinetobacter, Staphylococcus pneumonia, and Haemophilus influenza. This pneumonia are often first suspected with demonstration of new or worsening radiographic infiltrates, along with other clinical signs of infection, including fever, leukocytosis, and purulent sputum. The clinical must evaluate various findings what are not specific to nasal pneumonia, including the following: fever, elevated white blood cell count, worsening oxygenation, new or worsening pulmonary infiltrate compatible with a bacterial pneumonia, is not diagnosed based off respiratory secretion cultures. Physical findings is not specific. The white blood cells count may be normal or elevated. The degree of left shift indicates the degree of stress in the host. Traditionally, nasal pneumonias have been treated for 7 to 14 days. However, ventilator-associated pneumonia can be successfully treated in 7 days. Direct empiric coverage against common nasal pathogens Pneumococcus aeruginosa, Klebsiella species, Escherichia coli. Coverage against Pneumococcus aeruginosa also covers other nasal pneumonia pathogens. Ventilators associated pneumonia is a type of pneumonia that develops more than 48 to 72 hours after endotracheal intubation. Treatment. The major factor in the selection of agent in the presence of risk factors for MDR pathogens. Patients without risk factors for MDR pathogens used ceftriaxone or cefotaxime or moxifloxacin, ciprofloxacin or levofloxacin, ampicillin, sulbactam or ertapenem. Patients with risk factors for MDR pathogens. Beta-lactam, ceftazidime or cefepime, piperacillin, tazobactam, imipenem, or meropenem. Second agent active against gram-negative bacterial pathogens, gentamicin or tobramycin or micacin, ciprofloxacin or levofloxacin, and agent active against gram-positive bacterial pathogens, linezolid or vancomycin. Complications of pneumonia includes abscess, empyema, parapneumonic effusion, common retention of sputum causing lobar collapse, deep vein thrombosis, and pulmonary embolism, pneumothorax, particularly with Staphylococcus aureus, suppurative pneumonia, lungs abscess, ARDS, renal failure, multi-organ failure, ectopic abscess formation, hepatitis, hepatitis, pericarditis, myocarditis, meningoencephalitis, pyrexia due to drug hypersensitivity. Dear students, thank you for your attention. Goodbye.